Thank you. It's a pleasure to be here. And my talk is going to line up nicely with Dr. Rawlings. I come to you from a bit of a different tribe. I come to you from the trauma and acute care surgery tribe. There's many similarities, though, between SAGES and the American College of Surgeons Committee on Trauma. Many similarities. If I had to do one thing, I would ask you to stop using the word accident. From our side of the tribe, we don't consider anything an accident. We consider all these things to be preventable. An accident is an act of God. So, and I'm going to try to convince you not to use the words gun control. And I'm going to give you my rationale for that. I'm going to start, though, with my personal experience. And what I'm going to convey is not my personal opinion, not my political opinion. It comes from decades of advocacy from the COT and 5 years of collective effort, inclusive dialogue from all points of view, and consensus building. I'm going to talk to you about the Sutherland Springs, Texas church shooting. I'm going to talk to you about the COT's approach. We probably won't have time for action steps. We can do that afterwards. Even if you don't really care about this issue, we are at a crossroads. At stake is whether we can actually solve even moderately complex problems as a society. There is overlap between a lot of things that have been discussed on this panel. If I were to say what's the underlying, there's an underlying connection between violence and addiction, and it is the degree of connectedness in a society. But that's a whole nother talk. It's a very important topic. So I'm going to talk to you about Sutherland Springs. I work at University Hospital, which is here. Brooke Army Medical Center, San Antonio Military Medical Center is here. This is San Antonio. This is Sutherland Springs. This is Conley Memorial Hospital in Floresville, Texas. It's about 40 miles between those places. Sunday morning, November 5th, we were in the hospital, in our hospital, because we were having a focused site visit from the American College of Surgeons Committee on Trauma Verification Review Committee because we had 2 criteria deficiencies for performance improvement. So at 7 a.m. we were in the hospital, but at 11:20, a lone shooter crossed the street to a church, and sometime about 11:25 started shooting. And he shot 46 of approximately 50 people in the church. At 11:27 was the first dispatch from law enforcement and EMS. 4 minutes later, law enforcement and EMS arrive. The shooter flees, is pursued and shot by a Good Samaritan. The Good Samaritan may have stopped the shooting inside the church because, by some reports, he was returning fire against the person. But within 4 minutes, this was over. Conley Memorial Hospital, that small rural level 4 hospital, who, by the way, did a terrific job, picked up scanner traffic about 10 minutes after the shooting. By 11:37, there were 10 EMS agencies dispatched along with 3 air medical providers. About an hour later, seems like a long time I know, but the first EMS responder is 1 ambulance, and there's 50 people shot in the church. But the first patient arrives at Conley Memorial Hospital at 12:25, 7 minutes later to Brooke Army Medical Center, SAMC, and about 14 minutes later to University Hospital. 8 patients go to Conley Memorial, 8 patients go to SAMC, 9 patients go to University Hospital. There were 26 total deaths. 25 of those were on the scene. 1 death was in the operating room at University Hospital. I was taking care of that patient. So the hospital mortality rate's 5%. The total event mortality is 55%. These are the deaths. 50 people in church. The little girl in red is the patient I took care of. These are the pictures. So what was the trauma system response to Sutherland Springs? What was the response? I'm going to kind of break it down. So this is my simplified view of the pillars of a modern trauma system. It really rests on these pillars. Prevention, acute care, that's what typically we do, rehabilitation, and a framework for disaster response. These two pillars, acute care and disaster response, mass casualty response, require timely, structured cooperation and communication. How well your system does depends upon how well you work together, how well we work together. So this was our Southwest Texas Regional Advisory Council response preparation. We had done an active tabletop shooter mass casualty drill 6 months previously. I actually presented at the American College of Surgeons in October of 2017 and presented the Las Vegas shooting. So we had done a tabletop shooter exercise that the people who were there said, really, 50 casualties, that's 50, that seems, okay. So one of the messages here is none of us expect for it to happen in our community, but the question is, this is going to happen again. It's not a matter of if, it's just a matter of when and where. And these patients are going to come to your hospital. And if you think preparation is total BS, and if you think it is a waste of your time, and if you think it is not needed, that's what it is, because your leadership determines how your hospital prepares. Preparation is key. We've trained 10,000 people in our region for Stop the Bleed educational program. STRAC coordinated the pre-hospital response, coordinated complex distribution of trauma patients, air and ground assets, and then coordinated the mortality management for the next week so law enforcement could do their job. So an active shooter presents several mass casualty challenges. About 2 months earlier, we dealt with Hurricane Harvey, which has it's way different in scale, but you have days to prepare for a hurricane. You have literally 5 minutes if it's next to your hospital to prepare. So preparation, prevention, pre-hospital care, pre-hospital notification, trauma center care, integration, disaster response, recovery, and reintegration. So green is what I think we did well. Red is what I think we did poorly or could have done better. We get an F for prevention. We get an F. We get an F. We actually trained 10,000 people, and actually the first responders had basic bleeding control kits with them, law enforcement, and they used those. And some of those patients lived. The patients who we took in transfer, who we received, had great bleeding control at the scene. But there was not 50 bleeding control kits in that church. There was not immediate availability in that church, and not everybody is trained. So you can have a great trauma system that's prepared, that has great pre-hospital care, that does triage well, that has an integrated military-civilian component to it, that has an integrated trauma disaster response, and has a great rehabilitation program, and your mortality is still 55%. The message is clear. We have to turn bystanders into immediate responders. And even if we turned the entire world into first responders, it's not enough. It's not enough. So, how to do that? This is the COT's framework for firearm injury prevention for the past 4 years. Treat the problem as a medical problem, not a political problem. Look and evaluate violence intervention, violence prevention programs. They're great programs, by the way, for violent intervention programs. And we've pledged ourselves to provide the COT as a forum for a civil, collegial, professional dialogue focused on reducing deaths and injuries of our patients. What have we done? We've hosted a town hall for COT members. We've surveyed COT members. We've committed ourselves to avoiding discussion in situations that would be polarizing, and we've engaged stakeholder groups across the entire spectrum. We all want to be data-based. We all want to be data-based. However, and especially in this area, I've realized that confirmation bias is highest in this area than almost anything I deal with. So we want to be data-based, but we have to realize that we make up stories around the facts. We explain the facts to ourselves. So I'm not going to quickly rush through the facts because the previous speaker did a terrific job of doing that, but I'm going to just give you some little bit of context. These are what trauma centers in the U.S. see. This is about almost 1 million patients from NTDB in order of prevalence: falls, traffic, firearms, 4% firearm injuries. However, this is the burden of death: motor vehicle, firearms, falls. Why is it that way? Why is it that way? Well, because firearms is the most lethal mechanism, and those are concentrated at a small number of centers. This is the trend from the time I was in college to 2014, and you can see suicides, number 1, homicide, and unintentional injury in adults. If you look from around the time whenever I was born, you can see that we've made a lot more headway with motor vehicle injuries than firearms, which have been relatively flat except for these peaks in the 70s and 80s. Bringing you back to this mechanism, to the mechanism equal, I'm going to ask you to think about it a little differently too. Okay, so this is firearm, intentional firearm deaths. It's suicide and homicides. About 70% are suicide. This is just for comparisons, motor vehicle crashes since 1999. This is all intentional violent deaths since 1999. That's 175 people a day. And the problem, of course, is the mass shootings. Stories. There's 2 contrasting dominant narratives in America. Guns are important for freedom and safety, personal protection. And the person who adheres to this narrative most closely, most tightly, you can pretty much synonymously substitute gun and freedom. So gun control translates into freedom control in that narrative. The second narrative is the wide availability of firearms limit our freedom by putting us at harm and risk of death. And for the people who hold most closely to this narrative, you can substitute violence and gun. So gun control translates into violence control. Where do surgeons stand with this? Before we go there, I will say that this debate does not serve us well because incivility foreshadows violence. This is what violent people do. The person, before they kill them, they assume that they're worthless, stupid, not worth living, and they kill them. And the violent person believes that you must think the way they think, and if you don't think that way, they're going to control you. It foreshadows violence. Trying to get it to go. Next slide, please. We need a common narrative, a narrative that resonates with a large portion of Americans, a narrative that leads to creative problem solving the way sages solves problems using technology and partnership. We need a narrative that focuses ourselves on reducing injuries. So I'm going to propose this. Firearm ownership is a liberty protected by the U.S. Constitution. However, we have a big violence problem. But we can reduce violent injury, death, and disability by working together to reduce violence and make firearm ownership as safe as reasonably possible. This is the way we deal with other things. How do surgeons feel? About half adhere to that first narrative, that firearms are beneficial and a critical liberty. This comes from the COT and the Board of Governors. About a third adhere to the second narrative, and there's about 15% in the middle. So 85% adhere to one of these 2 narratives. That's why it's so difficult to have the conversation. But you can have the conversation. You can have the conversation because let me tell you what this same survey shows. They agree that this is a big priority, that we should do something about it. Next slide, please. 90% of surgeons surveyed, more than 90%, agree on 7 of the 15 things policy-wise surveyed. Next slide. Next slide. Only a few areas is there great controversy. Next slide. So, wrapping up, violent intentional injury is the most poorly addressed public health problem in America. There's two polar sides to this debate, but they can work together. They can and they must work together. We need to form a common American narrative that frees us from the way that we tell stories to ourselves that divide us. If we focus our efforts on understanding and reducing violence while making firearm ownership as safe as reasonably possible, we will literally save thousands of American lives every year. Thank you.